Hello, sir. Hello, sir.
Good good evening. How are you?
Good evening, sir. I'm doing great, sir. How are you? Hope you are doing great.
Are you able to see me and hear me well?
Yes, sir. Yes, sir. I can. Can you hear me,
Yeah,
sir? There is some interruption in your video and your audio. A little interruption,
okay. I now can you to
sir. There is just a
can
little
you hear
interruption.
me?
Yes, I can hear you now,
Just raise the volume.
sir. There is some little interruption, like the internet connection is having a little bit of interruption, so your voice is not smooth. It's getting a little interrupted. Hello, sir. Hello, sir. Hello, sir.
What about it now? Is it any better?
Yes, sir. Sir, it's better now.
Good.
Yes, sir.
Thank you.
It's
Let me now
definitely
share.
better. Yes, sir.
Let me share. If
Yes, sir.
are
I
you
can see. I can see.
just 1 second? Let me just see if I can now forward because sometimes forward will be a problem.
Yes, sir. Exactly. And if there are videos, you can also check them so that we can make sure that everything is doing great here. So it does happen sometimes that the internet connection gets a little interrupted, even from our side. Sometimes it gets a little, something not quite smooth. So it's like quite natural nowadays in the meetings that sometimes the videos cannot be played so smoothly, or the voice gets interrupted. The sound system is not very smooth like it should be. So it's I think some technical issues all the time.
You are able to see the pointer as well now, correct?
Yes, sir. I can see. I can see. It's
Okay,
very
so
good. Yeah. Right.
I
Yeah,
will
exactly.
I will stop sharing.
Sure, sir. Sir, I'm just trying to send the invitations, the invites again to some of those attendees who have been registered. And third, thank you very much again for your time. I know it's a very hectic schedule for you, so it's an honor to have you with us today.
In fact, I feel privileged, and I know it is long due. When I was in New Zealand more than 8 months ago, we were having this exchange. But let's see how it goes. If it goes well, we can do the one or many. So don't worry.
Yes, I'm looking forward to it. Looking forward to more of your talks, sir. I have read your work. It's really amazing. You have been a wonderful mentor and a very good teacher.
That's my passion. So thank you.
Exactly, sir. Sir, I think that everyone will start joining shortly. We are just 17 minutes ahead.
Yeah,
So just 17 minutes, we have blocked
we,
none. Just
we yeah
so
we take a break. We can both go away. Now we have and we can come back another 5-10 minutes later.
Sure, sir. Sure, sir. I'm going to keep promoting the event so that everyone has, you know, a knowledge
My
that we are online.
Just a personal note, my best friend and my buddy Harshad
Yes, sir.
Parekh is a very
Yes,
eminent
sir.
from Mumbai. He has already joined. So let me greet
Yes,
him.
sir.
Are you there,
Yes.
Professor?
Let me ask him. Uh, Dr. Harshad, can you unmute yourself?
Yes, I did unmuting. Hello.
Professor, Professor,
Professor, how are you?
uh, bus, I'm touched by your presence, sir.
I'm waiting since 5 o'clock.
Oh my God.
Yeah. As soon as Dr. Noor joined, I joined.
Yeah. Dr. Maria, Arshad Parekh and I grew together. We are more than
Wow.
friends. We are almost neurosurgical twins, you can say.
Really, sir? That's amazing, sir. And he's a very good colleague also. He has attended several of our talks. So
Yeah.
he's like, yeah, I
He's,
really appreciate him.
he's a, the only thing he has remained young while I have got old, but he's still.
He's a wonderful friend. Dr. Parekh, you can also turn your camera on.
Yeah, yeah, I'm on.
Hi,
He's
sir.
Uh,
only young.
Hi, hi, hi.
Good. We all have 5-10 minutes to go away, but I thought while you are there, I best greet you and salute you. And
Yes, Professor, I was looking forward for your talk.
let's see what it comes. I hope you
Yes.
don't pull my leg, Lotus.
No, no, Dr. Noor always brings top class people of the world.
Today is the only exception.
No, it's a
Dr. Noor
continuation.
is, you have got in the line of Professor Spetzler now.
Oh,
Oh
really,
my.
sir? That's huge.
Dr.
Okay.
Noor has a connection with everybody.
Yes. Well, if he's connected to you and me, that means the whole world is all right.
And she is a very enthusiastic, very enthusiastic.
I'm very touched by her perseverance. In fact, and I'm a little bit apologetic that it took me a while, but I'm happy today.
No, no,
I
sir. No.
spoke to, when I was in Dubai, I spoke to their Pakistan chairman. I said, "Ki Dr. Noor is so active." And he said, yes, yes, he is from our hospital. Like, wonderful.
Dr. Bashir, Professor
Yeah,
Bashir.
Yeah, he's my teacher. He's my
yeah,
teacher.
yeah. We met everybody in the Dubai for the
Yes.
World Congress.
Yes.
Salman is our good friend. Salman is a
Yes.
good friend. Yeah.
I
Salman
know.
was there. He introduced me to him.
Yes.
Yeah, yeah, yeah. And I told also, okay, yes, I don't miss Dr. Noor's talks every time.
Really, sir? So
Yeah,
kind
yeah.
of you, sir.
No,
That
no,
that's
it's
that.
enjoy. No, no, you are getting all good people all over the world, top notchers, and we learn from them. Like today, I'm learning from my good friend, Professor Bhatt.
Oh my God.
Yeah.
That
Let's
you
go.
are
Let's
amazing, sir.
go for 5-10 minutes break, and then we come back again because
Okay, okay.
Sure, sir.
Catch you in 5 minutes. Yeah.
Dr. Hashad,
Okay.
would you like to deliver any lecture yourself ever in
Yes,
the
yes,
series?
yes. I'll get back
Please.
to you for that. Yes.
Yeah, I'll be looking forward to that.
Thank you. Thank you. Thank you.
Thank you so much.
Thanks. Thank you.
Thank you. Thank you very much. So everyone who has joined, we will be starting shortly, in about 12 minutes from now. Just a brief that this time I will be sharing a link for you to download your certificate of attendance after the webinar is over. There will be no questions or MCQs this time, obviously, but I'm going to start those again. And I also want to tell you that we are we are publishing a new book, and hemostasis in neurosurgery is one of the chapters we have added in our new book. I think it's one of the very, very something that all of the trainees really wish to know more about. So we thought about this chapter very, like very briefly. I discussed with Professor Borba as well that we want to add a few couple of a couple of topics that we should that we believe that our our uh, attendees and our viewers will appreciate. So I believe that you will certainly like our new book that's coming out in later this year, I believe. So today I've been in talk with my um, publisher as well in this regard. In the meantime, please share where are you from in the chat box. Feel free to use the chat box to share your questions and your comments. And as you know that our patron is, we will discuss all the questions and comments at the end of the session. So like before, we will take all your questions at the end of the session, and we will also allow you to turn your camera on or your mic on if you want to ask the question directly with Dr. Pragnesh Bhatt, and also feel free to share the link with your colleagues. I'm also currently sharing this link with on my social media. So hello and welcome everyone to the webinar. As you all know, that our webinars are certified, and you will be able to download your certificate of attendance at the end of the session by just clicking the link I will be sharing at the end in the chat box. You just have to click the link and just enter your name, and your certificate will be emailed directly to you in your inbox. So please share where are you watching this webinar from. It will be a matter of great joy to see where are you from, and we will be, it's a great opportunity to sit together and learn together. And also please use the chat box to share your questions and your comments, and we will take the questions at the end of the session. As you know, that's our routine, that's how we do our webinars. So again, thank you so much for joining the webinar and for your continued interest and your trust and your very kind words. Dr. Harshad has been so kind. His words were so encouraging for me. He's a wonderful friend and a colleague. And also, I want to share that we are, as you know, that I'm also currently a member and the lead of the webinar subcommittee and newsletter and the joint committee of the Women in Neurosurgery subcommittee of the WFNS. So I want to tell you that we have got some new initiatives for women neurosurgeons under the WFNS WINS subcommittee, and please stay tuned. We are going to inaugurate our first newsletter, an independent newsletter. I have got the honor of inaugurating, coming up with this idea, and leading the newsletter subcommittee under the chairpersonship of Professor Mirna Subena. And this newsletter is a really landmark, in the history of WINS WFNS subcommittee. So please stay tuned in the coming days. On 8th March. We will be you will be able to see our wonderful newsletter, and under the WFNS WINS subcommittee, we will be starting some new initiatives for women neurosurgeons, particularly including, there are so many things that we are yet to tell you, and we will be happy that you find about all those projects yourself in the newsletter. And also under the double ANS, we are having a little Women's Day special webinar where we will be, hosting Professor Jennifer Molitano from Yale University and Professor Kate Tremont from the Royal Melbourne, hospital, which is you all know both of these ladies. These are the leaders in neuro-oncology, and it's an honor to run the education committee as the co-chair with for the double ANS CNS joint sexual tumors for me as well. So please do attend that webinar also. And we are also having under the double ANS, there is another webinar by Professor Michael Lim. Please do join that one. And for the news, there are going to be new lectures soon we are scheduling. And also, I believe that many of you already know about my Neuroplex series. We will be launching it real soon. The teaser of the first episode is already on my YouTube channel. You will be happy to see. And I'm also going to start the New Reflex live series. New Reflex is basically, something interesting. You will be able to find some of the clinical dilemmas, and there are, like, it's basically a concept. It's not going to be simple case discussions. It's going to be a concept. We are going to communicate something more important for your clinical practice, for diagnosis, for management, and for, guessing the prognosis. So it's going to be something interesting. And for more, common cases, we will be starting a new Reflex Lite version, and it will contain more common cases that we see come across each day in our practice. Yes, sir. Welcome again, sir. Hello, sir. I think we have got just 1 minute. I think I can start with a brief introduction. Thank you very much, sir. So it's an honor, as a matter of real honor and a pleasure to welcome Professor Dr. Pragnesh Bhatt. He's, he doesn't need any introduction, and most of us know him very, very well, especially those who are more concerned, connected with the British neurosurgery. We all know him so well, and we really appreciate him. He's a legendary neurosurgeon and an educator. Dr. Pragnesh Bhatt is a consultant neurosurgeon based in Aberdeen with extensive experience in both cranial and spinal neurosurgery. He has strong academic interest in neuro-oncology and complex skill-based surgery and is deeply connected and committed to surgical education and mentorship of the next generation of neurosurgeons. So he's basically at the Aberdeen Royal Infirmary, and you might have attended some of his courses and some of his lectures before. So it's a matter of real honor to have him today to discuss hemostasis in neurosurgery. It's one of the, it's an important topic, especially for the trainees, and it's a very pleasant coincidence that we have, you know, uh, as you all know, that I have a book with Professor Luis Borba on basic cranial neurosurgery. And again, we wanted to come up with another book. When we released the first one, we, detected that there were a few chapters that should be added that were deficient from the in the first one. There were some basic concepts that needed some emphasis. So we added a chapter on hemostasis and neurosurgery in our book. It's going to be released later this year, and I just talked to the publisher as well just a few minutes ago, and he was like, "There is a lot you have given to us this time, so you are going to appreciate it." So please help me welcome please help me welcome Dr. Pragnesh Bhatt to start this webinar. Sir, thank you very, very, very much for your time and for accepting our invitation, because it was a great wish of mine to have the pleasure of welcoming you. So the podium is all yours now. Thank you very much again.
Thank you, Dr. Maria, for the invitation and more so for the general introduction. I welcome my friends from across the globe. I can see my best friend, Dr. Ganesalingam from Singapore has joined. My friend, Dr. Parak has joined from Mumbai, and there are many others who I know, but I won't name them so as not to lose a lot of time. Now, let me share the and I hope I am audible and visible. Am I audible and visible?
Yes, sir, it's perfect.
Good. Now let's see whether the technology works. So when we trained in neurosurgery, almost began 40 years ago, the main emphasis was on hemostasis, and we did not have so many technical advances. So some of my talk will cover the history of hemostasis, in particular with reference to neurosurgery. There will be a lot of science and little bit of humor, which is my second specialty towards the end. So let's see how the slide progresses. It is always a challenge, but I'm once again very grateful to Dr. Maria for inviting me for this. Now, little bit of introduction about Aberdeen. Aberdeen, as you see on the top right corner, there is a map of the world with the Aberdeen being on the northeast of Scotland. It is the final station of neurosurgery in the mainland UK, and this is our campus with a helipad with a pediatric hospital. It has expanded much more in my last 18 years of stay here. It is one of the largest single site healthcare complex in Europe. And a word about the Aberdeen University. Uh, some of you may not be aware, but together with Healthcare Compass and Aberdeen University, there have been five Nobel laureates till date from Aberdeen. And Aberdeen University was established in 1495. So we are just about 530 years old. And the greatest pride is that first chair in medicine in English speaking world was established in Aberdeen 2 years after the university was established in 1497. So with that introduction I come to the main topic, and I must disclose that once upon a time I was invited by Baxter to give a talk, because I teach regularly on Zoom. boot camps, and my topic is hemostasis in neurosurgery. So they had asked me to talk to other group of professionals also, and I have also borrowed some of the slides from their medical director, Dr. Sumit Jindal, and I owe some of the slides to his presentation. As you know, in neurosurgery, bleeding is our enemy and coagulation is our friend. When I trained, we did not have so many gadgets. We did have microscope, we did have coagulation, but we didn't have navigation. Cusa was just coming in, and lots of modern hemostatic products were not available. So I am going to talk little bit of history, but our emphasis will be, as we say in our cultural sense, that apne haath Jagannath, the best equipments and the best hemostats are these two. So with that note, let me see if we can advance. So as this paper says, that confidence gradually acquired from mindfulness in controlling hemorrhage gives to the surgeon the calm, which is so essential for clear thinking and orderly procedure at the operating table. Now, some of you may be knowing that Sir William Harsted, who was with those who have done general surgery before embarking on neurosurgery, you may remember various mastectomy procedures, modified, radically modified, etc. And Halsted, William Halsted was actually the mentor to Harvey Cushing. So I'm going back to not only father of neurosurgery but the grandfather of neurosurgery, William Halsted, and that quote says that controlling hemorrhage is one of the most important technical skill in neurosurgery. And when we were trainee, when the boss lets us close the wound, that means boss is confident on our ability to control the hemorrhage, and that means we have achieved significant milestone. Little bit of physiology. uh, Let me see if this thing coming in the way, maybe sometimes they can't see. I Are you able to see the title of the slide, because there is something on the top of that maybe yes, okay. So
Yes.
as you all know, hemostasis is a physiological process that stops bleeding at the site of an injury without forming clots elsewhere in the circulation. This all we learnt in medical school, so I'm not going to dwell on that much. uh, but we will talk about these two cascade: extrinsic pathway on the right and intrinsic pathway on the left of the slide in light green color, with a common pathway at the bottom in beige color. We all know, we learnt it in first and second MBBS physiology, so I won't bore you with that, but that is important and we'll come back to it later on. Why do patients bleed? This paper tells us all the reasons why patients bleed, and these are the causes. We know that, of course, first of all, if we are operating on a live tissue, then of course, because of the circulation, it can bleed. Then there can be some tissue or collagen disorders. There could be drug related causes, and in the current day and age it is more relevant because of one, increasing population, aging, and two, with lots of comorbidities. Many of them are on antiplatelet and anticoagulant agents, so therefore they could also have some other comorbidities like liver disease, vitamin K deficiency, renal failure, and others. And of course, some of them may have blood dyscrasias, congenital disorders like hemophilia and von Willebrand disease. So we have to keep thinking of that, and mostly our anesthetist and hematologist help us if there is a planned operation. But in emergency, we have to be very vigilant about making sure that all this have been taken care. Coming back to the various methods, they are divided into three main categories: mechanical or physical, which is not very commonly used in neurosurgery except in the superficial planes. Then we talk about thermocoagulation, electrical, and last but not the least, chemical, which is the mainstay of the modern day. Now, some of you may have seen this device. It is called Dandy's forceps, and you can see, as against most of the other forceps which are curved on flat, this is curved on edge. So because that is how we were using it. So you can see, instead of on the flat, it is curved on edge, and you will see it in action. This is what we used to have when we were opening the scalp, and the trick here is not to catch every blood vessel but to catch gallia. And when we bend it over, and after applying 4 or 5, we will tie those with the rubber band. And this is what Dr. Parekh and I and many senior neurosurgeons in across the world would have grown with. This was the mainstay when we were using scalp opening uh, for the cranial procedures. Then came this Rennie clips, which you all are familiar with now. Initially, they were in metal format and they could be re-sterilized. Nowadays, we get this disposable plastic one. The advantage is that they are safe and reliable. They have automatic design. They have constant closing force. It does not restrict the operating site, which is the most important advantage as against the dentist forceps. And they are fast and easy application. Uh, as I said, the latest plastic design is one which guarantees cleanliness and sterility. And they can also come rather than having individual to be loaded. They are also available in gun form so that there are 10 about which you can apply in a very quick succession. Coming back to bone waxer Victor Horsley, who are familiar with the history of neurosurgery, you know that Sir Victor Horsley is known for two things. One, he had a Horsley Clark stereotactic apparatus, and he is also known for operating the first spinal tumor, which was diagnosed by Sir William Grover in National Hospital for Neurology and Neurosurgery, which is famously known as Queen Square. Now, he was appointed to Queen Square, but before his appointment to Queen Square in 1885, while working in a laboratory, he came across this product and developed this, which has original components where 7 parts of beeswax, 1 part of almond oil, and 1 part silic acid. He was inspired by Magendie, the famous Magendie of foramen of Magendie and Lusca, that Magendie. The current wax available has got 88% refined beeswax with 12% of isopropyl palmitate. It is effective on bleeding from bone. It is also helpful not only from bleeding from the bone surfaces, but also in a very big venous lacuna to prevent venous air embolism. And I would say a word of caution in that in spine operations, when you are doing extensive decompressions, every other bleeding will stop, or you will be able to the bleeding from the bone and we had to have a technical with more and we used to hedging technical in the whole neural career. The word of it acts as a foreign body and source of infection, and in a very narrow space in spinal small decompressions it can lead to space occupation also, and same thing in foramina in skull base. So be careful not to leave a lot of bone wax behind. Dr. Maria, am I going at the right speed and am I still audible and visible?
Yes, sir. This is perfect, sir. And the floor is all yours. You can take as much time as you like because we are all so much interested in listening to your talk. So please, sir, time is no restriction for you. And there was just a little interruption in your internet connection for a very brief moment, but it's smooth now.
Thank you very much. So, coming back to the father of neurosurgery, Harvey Cushing, as we know, muscle is a very good source of tissue thromboplastin. And many times in the good olden days, when we used to deal with aneurysm surgery routinely, and if we wanted to help the situation with a little bit of blister, we used to crush the temporalis muscle and have a ready and fresh source of tissue thromboplastin. It also can act as a mechanical uh, force, and it has been used many times even on the big sinuses opening. It can be used, but making sure that it does not plug the sinus off. So perhaps on a thin piece of surgicel, if you lay it over, then we are talking about physical cotton balls and linen patties. As such, in neurosurgery, physical method of hemostasis is not very commonly used because we cannot press on sensitive neurovascular structures, which includes brain, spinal cord, nerves, etc. But gentle pressure is occasionally allowed, and we use cotton woolly balls of various sizes and linen patties of various sizes. In fact, in our training time, we were not allowed to touch any part of the nervous system directly with an instrument. There has to be have linen patty as the medium between the instrument and the neural surface. And as I mentioned, we can only have gentle pressure. Coming back to the metal clips, again in good olden days, this is a quote from Coleridge. Cushing has written this quote: "The thought has doubtless occurred to many that much time and trouble would be saved in major operations could there be devised some form of hemostatic clamp, the mere placement of which would leave a fine knotted ligature on the bleeding point so as to obviate the alternative which we now possess, either of leaving a pendant instrument or taking the time necessary for ligation." So these silver clips, they used to be in silver design originally, and we used to have a little palette with re-sterilizable. Nowadays, we get it in the four different sizes, as seen on the left bottom, with a very small, micro, medium, and large, and with an applicator, as you see on the right. And it has become a little bit easier. We still routinely use it on the sinuses, especially in posterior fossa dural opening. If I were to
नारियल
take
देखा बना के रखता हूँ मुझे
circular
देते हो
sinus. Sorry, can
हाँ
we
जी
can
आया ना
we sorry, can we mute all the listeners, please? Thank you. So, coming back to the presentation, this is very commonly used nowadays. There is also another use sometimes we used to have, that if we were saying dural AV fistula in the spine, if it may be a good idea to leave a little silver clip there, so that in the future imaging we can confirm that yes, we were at the correct level. Because one of the important points of dural AV fistula surgery is to be at the correct level, which we take help of radiologist and all preoperative marking to ensure that we are at the correct level. But this was another way we used to ensure that we have been at the correct level. Now, looking at this, this is a lot of responsibility, because as a neurosurgeon, we are responsible for someone's life, and when we are given the weapons of power, we have to be very judicious in using those. So I will give you a minute to read this quote. And this is where the electrocautery started. Some of you may know that in the current day and age, you are all allowed to use the drill. I'm giving an analogy very easily, but in my time, for before starting the use of drill on real patients, we had to be trained in the Medtronic lab, and we had to take the eggshell off with the drill. Similarly, there used to be a regulation for learning how to use cautery in good olden days, but I was already fortunate that those regulations were not there. Little bit of history about electrocoagulation. It has been practiced more than thousands years ago. In Hippocrates' time, a hot iron rod was used as a sealer, and then albucasis used in 18th century for selective use. Then there are various others. I won't go into the details, but the most important thing, Doyen, you may have heard in abdominal surgery, Doyen's retractor. So about 120 years ago, they used the large different grounding plate. Um, Bobby Cottery that we know almost 100 years ago, and most importantly, Harvey Cushing delivered Sir William McEwen Memorial Lecture. Sir William McEwen used to be an eminent neurosurgeon in Glasgow. He is known for the best ever results in cerebral abscesses in the time where he did not have modern imaging facilities, and neither were all the modern antibiotics. So Sir William McEwen Memorial Lecture was delivered by Harvey Cushing in 1927 for British Medical Association, talking about olfactory groove meningiomas, and that is when he first mentioned about the use of electrocautery in neurosurgery. And then, of course, William Sachs and Walter Dandy were the one who followed it further use. The electrocautery is used for two different purposes. One is for cutting and one is for coagulation. When the energy is low, then it causes dehydration by heating, and therefore the cell is coagulated, and that helps to coagulate. While when you use intense energy, the cell expands and is exploded, and that's how it helps cutting. So we use electrocoagulation both for electrocautery both for coagulation, cutting, and usually we have yellow, which is cutting, and blue, which is for coagulation. Coming to monopolar, there are some contraindications that you all must be familiar with. If patient has got a defibrillator or metallic implants or flammable liquids have been used, and therefore we normally suggest not to use alcohol-based solutions for sterilization or cleaning the surfaces before using the electrocautery, because there have been instances of fire. And other cautions are the earthing pads should not be put on bony prominences, on scars, or on metallic implants. On the other hand, bipolar, and some of you may be familiar with this, Leonard Mallis, who used to be a neurosurgeon in Mount Sinai in New York, he designed this equipment, which is very commonly seen in most of the neurosurgical theaters currently, Mallis bipolar, as we call. And there are advantages, of course, here, that it does not transfer the current throughout the body. In monopolar, the current is transmitted between the point of cautery to the earthing plate, so it goes through entire body, and there is more charring and more tissue damage. So it is only used for subcutaneous and muscular plane, and very rarely in dura. For example, when you are opening for chronic subdural hematoma and if you want to coagulate the dura, you can use low current monopolar. But by and large, we use anything from dura onwards bipolar, and the reasons are that there is less tissue damage, less tissue charring, and the current is only transmitted between the 2 points of the forceps, so there is no extensive tissue damage. And one of the things I asked my trainees, and one of my trainees already on this attendance here, so she will know that I ask usually that if you want to kill your enemy, how many bullets you need? And the ideal answer is only one, because if you're a sharpshooter, you only need one bullet to kill the enemy. Therefore, the analogy here is that if you are experienced enough and you can identify the source of bleed, then you can use the bipolar to the lowest current possible. I think the idea of using higher current bipolar comes from that you are unable to identify the source of bleed, and therefore you are hitting a blind target surrounding the bleeding point rather than the bleeding point itself. So the more precise your dissection and microsurgical skills are, the lower current you will be able to use and still achieve the hemostasis without affecting the nearby tissue. So I would say lower the current, higher is the surgical skills, and equal amount of hemostasis can be achieved. We are now talking about I can't read the top line, so let me just see, because for some reason that keeps. We are now talking about the thermal. It enhances platelet aggregation, release clotting factors combined with plasma factors to produce fibrin clot, and could be used on bone. um Loses effect in severe thrombocytopenia. So, as my teacher used to say, therapeutic cheating not to be tried without presence of the parents, as some of the television program tells these days. So, very rarely you can use monopolar coagulation on the bone edges, especially if you are able to see and if it is not close to any neurovascular structures. Topical agents is what you all are currently using. They are the most important factors to consider are their safety, efficacy, usability, cost, and availability. Most of the people in the affluent world don't bother about cost, but I still see their point on trying to be judicious in using all the topical agents. And I tell some of my trainees to say that the day I have to use Flowsil, I observe fast, because that means I have failed in my basic fundamental skills of coagulation. The chemical that agents that we have are gelatin sponge, microfibril collagen, and oxidized cellulose. We'll talk about those. So coming back to gelatin sponge, this is what we used to have when I got trained in late 80s. It was uh, invented in 1940s. It comes with a purified pork skin gelatin. A little word about it in a minute. It forms matrix, absorbs 45 times its weight, expands up to 200 times, and it can be used either dry or saline soaked. A word of caution that it cannot be used with salvage, Many long or extensive spinal operations, including scoliosis, etc., when there is likely to be a significant blood loss, many people employ cell salvage. Word of caution: because of the filter size, 40 millimeter, the gelatin sponge cannot be used, otherwise it will block. Now again, coming back to this expansion up to 200 times, it cannot be used in narrow spaces, especially in neural foramina or the skull base, or in the spinal operations. I have seen examples, not in my own practice but in my colleagues practice, that with the expansion of these hemostatic agents, neurological deficit have resulted, and it has to be re-explored to remove this sort of pieces to reverse the neurological deficit. So be very cautious in using it in small spaces when the expansion is likely to cause neurological damage. The microfibrillar collagen, one of the companies have taught that the currently most commonly used or ideal substance to use is either microfibrillar collagen, or they call Surgicel Snow. There is also something new kit is also available. In our time, it used to be only mash form. It is derived from bovine skin. It causes minimal swelling. Matrix is caused to prevent clot formation. It enhances platelet aggregation and release of clotting factors combined with plasma factors to produce fibrin clot. It loses its effect in severe thrombocytopenia, as we see earlier, and could also be used on bone. So, especially the powder snow can be used in on bone, and we currently use in my own practice microfibrillar very very thin layer. Whereas as my experience has grown, I use lesser and lesser amount of artificial means, and if I use in the like big tumor cavity or on the surface, if there was any injury, then I would try to remove it towards the end once the anesthetists have confirmed that the blood pressure is not going to rise any further. We are almost halfway through, so you can all be relaxed. We were talking about oxidized solutions. Again, it is a polymer. It is regenerated into continuous fiber, knitted gauze, and oxidized. It is absorbed within 4 to 8 weeks. It is acidic and therefore bactericidal. One of my junior colleagues used to say, who is now a big time professor in Edinburgh, he used to say that Surgicel can be bactericidal. Cellulosic acid facilitated by denaturing blood proteins may retard bone growth. So those who are keen orthopedic spine surgeons or those who do big fusions, they try to avoid this because there is likelihood of some growth retardation and fusion. It also interferes with epithelialization. Now, the word of caution I wanted to use in all these products where there is animal component, like in food allergy or in food habits, we are routinely asked if you have any dietary restriction. One of my colleagues in Cardiff has done a very good study of while consenting the patient to ask whether they would have any objection in using any of these products that I mentioned, which has got animal components. So if they are a very strict religious follower, and currently this holy month of Ramadan is going on, we must be reminded that we must take care of individuals' religious or any other belief in using these products and consenting to include this aspect as well, whether they will have any problem of using, like we do for the Jehovah's Witness about the blood products. This also should become a routine practice, that we must consent patients for allowing us to use or not to use this animal derived hemostatic products. The flowables, which are the most trendy things, and I see that some of the juniors, before they enter the theater, they make sure that the nurses have already put these things out on the tray. I feel that is not a good practice. I think they could be available as a standby, because the moment you rely on these substances, I have nothing against them, they are very useful, and I'll give one example in a minute where I thought it should have been used earlier. But routine use of flow seal or Surgiflor or similar hemostat, makes you weak in your other surgical skills for hemostasis. So I would say yes, they should be judiciously used, they should be available, but only to be used when necessary. And we'll talk about that little later. There is a possibility of cerebral edema, and one of the examples, a giant of skull-based surgery, I believe Laligam Shekhar from US had quoted an example that in the beginning when these were available, somebody used it on the sinus and it went into the sinus, dural venous sinus I'm talking about, and that led to the venous sinus thrombosis and much worse outcome than otherwise. So we must be very careful that when we are given very powerful adjuncts to use, we must use those judiciously. And I am reminded of a famous quote by Lars Lexell, the father of gamma surgery, that fool with a tool is still a fool. Therefore, when we are given tool, we must exercise our own intelligence and depend on natural rather than artificial as much to use those judiciously. Again, I'm reminding you of the two extrinsic and intrinsic pathways leading to the common pathway. Sorry, it went further. So we are talking about tissue sealant. As we may know that these are used mainly as a tissue sealant, but they also have hemostatic product and properties. I'm giving example of this T-seal or AV-cell, which are human plasma derived. It has got two important components, fibrinogen and thrombin. Fibrinogen is converted to fibrin, and apotrinin inhibits premature fibrin degradation. So that is how it works, and it can be used also as hemostatic substance. Hydrogen peroxide. Unfortunately, we are not allowed to use in UK. I had privilege of using it long time ago in UK and in my Indian practice, and recently in my sabbatical in New Zealand, we were still allowed to use hydrogen peroxide. I think it was a wonderful agent, but as I said, it is now controversial, and in many countries, I think it is not allowed. I will ask the learned colleagues like Naren, Dr. Maria, and Harshad Parekh to see what their views are at the end of my presentation. But the mechanism of hydrogen peroxide is its obstruction of microvasculature, removal of tissue debris, vasoconstriction, and there is a possibility for surrounding tissue damage. So therefore, many places do not allow hydrogen peroxide to be used. I will quote one example. I was doing an ACDF. I am very obsessed about hemostasis. And at the end, when everything was over and I removed the retractors and I must have put some hydrogen peroxide, my anesthetist colleague warned me to say, "What the hell, Pragnesh, you have done?" Because the patient's blood pressure has gone from being normal to about 200 and tachycardia. And I can only explain one way that what must have happened, that when I was taking away all the retractors from the subcutaneous plane, the hydrogen peroxide must have trickled along the epidural space up to the brainstem, and therefore it led to medullary stimulation, leading to tachycardia and hypertension. With a profuse saline wash and putting the retractor back and letting all the hydrogen peroxide out within a fraction of 30 seconds or so, the situation calmed down. So be very careful when you are using hydrogen peroxide in the closed spaces and also when the ventricles have been opened, because it can lead to pneumoventricle and a lot of irritation can happen. But thankfully, many places are not allowing to use hydrogen peroxide, which is a PT, but also gives us chance to improve other hemostatic skills. I have no experience, I am being very honest, of using laser, but I must mention this as a completion sake that ND-JAG laser can be used for hemostatic substance. In head injuries, again, very late in my career, I came across an example because of some lack of register or so. About 7 or 8 years ago, I was doing an acute subdural hematoma in the middle of the night, and everything went well. I am always very pompous about my own hemostatic skill, but towards the closer, suddenly there was oozing from everywhere and nothing could be controlled. And I started blaming anesthetist as usual, but then anesthetist reminded me of the fact that the cortex has a very rich source of tissue factor or thromboplastin. And what must have happened is that due to this acute subdural hematoma and damage to the cortex, there was a massive release of this thromboplastin, which resulted into exaggerated fibrinolytic response and what is known as consumptive coagulopathy or DIC, and patient had a continuous oozing and massive hemorrhage. When we realized that with the correct transfusion of appropriate factors and using TXA and other adjuncts, we could control the hemorrhage. So remember that in head injuries, in especially in acute subdural hematomas where there is cortical damage or in contusions, there could be massive tissue release thromboplastin, and that can lead to hemorrhage despite of your excessive surgical skills. I'm reminded of again the antiplatelets that we use and various places that they work. And you can see that here the low molecular weight heparin or earth fractional heparin can block these two factors. Again, reminding of various modern agents like warfarin, apixaban, etc. I'm not going to go into the details, but you can see various agents that work on various places, and how many days you need to stop those. In emergency, of course, you use like some of the active agents, and take help from hematologist and anesthetist to guide you through the pathway. But you must be very careful in choosing the correct hemostats, but also using the other systemic factors as well. Now, coming to the final part of the presentations, we have seen all the adjuncts till now, and they can be classified into two categories, either active or passive. Passive are the old good days like oxidized cellulose, etc., and active are the one which are like flowables. The difference between them is that active will work independently of the patient's ability to generate clotting factors to achieve hemostasis. They work regardless of the coagulation status, and they work across a wide range of bleeding, while the passive will not work in these three situations. So, for passive to be used, patients' clotting mechanism should be intact and should not have a very massive hemorrhage when we come to talk about the grades of hemorrhage. So here are some examples of hemostatic products. I am not bought by any company, but just because of the ease, I have recently shown some of this from the Baxter, but I have no liaison with them. I am using all company products to my advantage and to patient's advantage. So there are flowables, there are fibril sealant, and something like patches like hemo patch. On the other hand, the standard forms like oxidized cellulose, gelatin sponge, and we talked about powders and fibrillar. These are some of the papers that I've used in my presentations, and this can be made available later on through good office of Dr. Maria. I believe it is recorded as well. Coming back to the scale, now in everything, as they say in science, we should be measuring, and the best example is of GCS. Our life has become so easy when we started communicating about neurosurgery through GCS. GCS, as you know, we celebrated in 23 50 years of publication of the original report in 1974. So it has made our life easy because we talk the same language. When someone says that GCS is 8, we know what we are talking about. Similarly, when we talk about the bleeding, if you use some scale, and I'm just giving an example of the one that I'm familiar with. So this Vibe E scale, validated intraoperative bleeding scale, is the first surgeon validated scale designed for consistent and reliable assessment of intraoperative bleeding. And why do we need scale? Because that gives us clear definitions, standardized evidence, and it helps us to select treatment. And as I said, we communicate. When I talk to my anesthetist and I say grade 2 hemorrhage, that means anesthetist knows what I'm talking about. And when anesthetist talks to the blood bank, it says that it is grade 4, that means it is massive hemorrhage protocol. Some of the places have this special code. Unless you use the word massive hemorrhage protocol, they will not supply indefinite amount of blood. So some hospitals have this policy to use particular word massive hemorrhage protocol. But what it means is that grade 4, and I will now show the 4. Grade 1 is very mild, with the bleeding is between 1 and 5 ml per minute. We normally call this ooze. There is a continuous flow which is moderate, and grade 2, where the bleeding rate is between 5 and 10 ml per minute. Uncontrollable bleeding or severe overflow is 10 and between 10 and 15 ml per minute, and unidentified or inaccessible gush is more than 50 ml per minute, which is life threatening. I think when we are talking about the life threatening hemorrhage, this massive hemorrhage protocol should be used. Now, a little bit of lighter sense as against these, I have my own bleeding scale, and some of you may understand. Grade 1 is when surgeon knows. Grade 2 is when anesthetist knows. Grade 3 is when the blood bank officer knows. Grade 4 is where coroner knows. And grade 5 is when the healthcare regulator and the media knows that XYZ has died because ABC surgeon could not control the bleeding. That is grade 5. I hope none of us land into that situation. But as a neurosurgeon, if you are working through all those types of operations, you will come across other 1 to 3 grade commonly. So with that, I'm coming to end of my presentation. There is another grading scale also, which is called spot grade, and it has from 0 to 5 grades. So there are 6 various grades. And here is, I'm not going to go into the details, but here is the comparison. Let me show you the comparison and then I will come back to you. So there is a comparison between the spot grade at the bottom and vibe E scale, which I mentioned at the top. And as you can see that the vibe E scale has got excellent reputation about validity of content and construct. And going back, it has been validated by more than 102 surgeons representing 11 different surgical specialties with excellent reproducibility to 0.91 among the surgeons. Among the same surgeon, there was a 98% repeatability, and as I showed, it has got valid content and construct. So with that, I am coming to an end. So again, I was mentioning that when you use some form of scale, I'm not saying you should only use vibe scale. We use vibe scale, but you can use some form of scale in your theaters so that the theater nurses, the scrub nurses, the circulating nurse, the anesthetist, the anesthetic assistant, and your team all are familiar with what you are dealing with, and appropriate help can be obtained. Reminding you at the end again that hemostasis is physiological. You are only assisting physiology. You are not trying to conquer the physiology. You are only assisting physiology by various products. And depending on whether you have got grade 1 or 2, or whether patient has got underlying coagulation abnormality or not, you can either use passive or active products. And these are the various companies, so that I'm not sold by anybody else. These are the various agents and various companies, so I am equal to everybody. With that note, I quote Einstein that geniuses prevent the complications while intellectuals solve. And when I was a medical student, one of my teachers used to say that all these subspecialties have evolved later on. Before my generation, there used to be surgeons who could do appendicectomy, tonsillectomy, hysterectomy, and fracture fixation. Then became general surgeons and orthopedic surgeons. Then became neurosurgeons. And now in neurosurgery, there are almost 8 subspecialties established: pediatric, spine, oncology, vascular, functional, trauma, peripheral nerve, etc. But the fundamental surgeon is still only 2 types: either somebody who coagulates and cut, or someone who cuts and coagulate, and you can decide which one is the better type. Thank you very much for patient listening. With that, I stop and am open for all questions.
Thank you very much, sir. That was a very insightful talk, and I hope that many of the neurosurgeons must have, I've received a lot of comments for you, sir. Everyone is really impressed and really learning from you. So it was an honor. And sir, I have got so many of your friends in the panel already, so I wish them to turn on their cameras and their mics so that we can actually talk to them and discuss and listen to their comments. Sir, you have a very good insight and you have have given a very nice guideline. And what do you think? Do you believe the trainees, you and the young neurosurgeons, the mistakes in hemostasis the young neurosurgeons and the trainees usually make in the OR? And what do you think? How they should be addressing their, their level of vigilance in hemostasis? I believe also that there are certain things like blood pressure control, and also the according to the lesion, whether it's a hypervascular region or whatever the lesion they are operating, that also dictates how to approach that particular condition. So what tips you would like to or what are the points you would like to emphasize for the trainees and the young neurosurgeons?
Thank you very much for a very good question. The first and foremost is positioning. I have seen, and this is a question we ask in interviews, that if you are operating on a trauma, craniotomy, and if there is a bleeding, many times I have seen when I join them is that the head position is not above the heart level. So the first thing I would say is that positioning, as they say, good beginning is half done. So one of the things always insist, except in the sitting position or in posterior fossa where there is occasional chance of venous hemorrhage, by and large keeping the head higher than the heart facilitates venous return and avoids venous oozing. So the first thing I would say, and this is an example we are asked many times, that you are operating a craniotomy in middle of the night and there is a oozing that you are unable to control, what would you do first? So the first thing is to make sure the heart is at a lower level as compared to the head. So that's number one. Secondly, keep anesthetists as your friends. There was a time before my generation that anesthetists were considered less important than surgeon. I have changed that in my practice and in my training. I have seen that they provide very valuable support. Discussing with them beforehand, especially for example, when we are operating on aneurysm, to say that there may be a time when we may ask you to lower the blood pressure, raise the blood pressure. And again, in my lighter sense, I say that there are various types of anesthetics. Some anesthetics can fluctuate the blood pressure without asking, and others who can do that at our request and according to our request rather than against our request. So keeping anesthetics on the right side is very important. And of course, using the all adjuncts, but starting with these two at the right way, so that, and I gave an example of a bullet, using the bipolar coagulation to the lowest current possible, but being precise at the site of bleeding point is what is very essential. In our time, we only had, Professor Parekh may agree, that we only had two things. We had a suction and we had a coagulation. We didn't have so many fancy gadgets, but we had to do all neurosurgery with those two things. And uh, I will give an example where I had made a mistake. And while I'm boasting about not using the modern gadgets, I was operating on a parasagittal meningioma. And there was oozing going on from the sinus because I was at the terminal part of trying to peel the parasagittal meningioma from the sinus, dural venous sinus, sagittal sinus I'm talking about. And it was oozing and oozing and oozing, and we continued to use all the techniques including head eye, while making sure that the operative field is flooded with saline wash so as not to encourage any venous air embolism, till a colleague of mine came and said, have you tried Flosil? And as I said, I normally don't, and I had not. And I must say that that was an eye opener for me, that once I used Flosil soaked patties, things came under control. So while I'm trying to reduce the use of such adjuncts, we must be very judicious that we must use those as and when required. And one of the last word I would say, I know it is a long answer, but it is very common for the trainees to always look for chance to operate. But I would say to observe and assist one good operation is better than doing 10 operations on their own in the beginning.
Exactly, sir. This is really important. And sir, also there are some overlooked and underrated things that include, what the lesion is and what, the physiology. We have to actually look at the physiology, look at the pathology, look at everything when we are dealing with the patient, with abs, with every situation. It's not like one size fits all. So it's like you have very rightly mentioned that there are simpler things before we get into more sophisticated ways of hemostasis. So also, what's your recommendation in typical hemostasis in difficult conditions of hemostasis in skull-based surgery, like the corridors, the deeper, the tighter corridors? How would you? What's your approach to hemostasis in those corridors?
One is prevention, and second is using all the adjuncts available.
Yes.
I have also
So
noticed.
there is any. Please.
Yeah, carry on, please carry on.
No, 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 please, please, please.
I have also noticed my own teacher, Dr. Shankar Athole from Mumbai, is on call. I know he's attending a conference in Nashik, and even then he has made efforts to join. If he's still online, can we unmute and ask him to say a word? Because I owe everything that I have spoken today to him.
Yes, sir. He's the co-host, and Dr. Shankar. Will you please unmute yourself? He can actually do it because he's the co-host now. When you mentioned him during the talk, I made him the co-host. He's a very active educator himself. He's always organizing amazing events. So let me message him also.
Dr. Parekh,
I
will
also
you say, Dr.
yes, doctor.
Naren wants to say, please. Naren,
Uh,
I'm very keen to hear your comment, please.
Thank you very much, Mr. Bhatt, and thank you very much, Dr. Maria. Excellent lecture, and I hope you can hear me well. I think the hemostasis is an absolute crucial skill. I don't think enough training is given for the skill when we start neurosurgical training. I think it will make a big difference for the confidence of trainees and then later when you become a consultant. Is it okay if I just, when you were going through the lecture, Dr. Bhatt, few points came to me from my experience. Is it okay,
Please,
Dr. Arya, if I just share
please.
with
No,
you a few of
yes,
them?
yes. That's why I added you in the panel so that you can
Uh,
actually discuss and say anything that you wish to. If you want to start the video, I think you are the co-host. I have made you the co-host. You can do it as well.
I will for now just speak. I will leave the video.
Oh, sure,
So
sure.
the first one is that when you use floor seal, I think it's most people do wash the floor seal off, but sometimes if you don't wash the floor seal and then get a CT scan, then the CT appearance looks like as though there's pneumocephalus. So I'll send the paper on the American Journal of Neuroradiology. So then you think, how come there's such a pneumocephalus, but it's just the floor seal has been not washed out. The second point is that when I was a registrar, I wanted to help my surgeon, and my registrars do the same, and they try to suck. And as one Mr. Solanki told me in Birmingham, you only want to use the sucker as the last resort. Otherwise, just use a gauze and just put pressure, because otherwise, every time you suck, you take the clots away and you kind of increase the risk of further bleeding. Then Dr. Bhatt mentioned about uh, positioning. I think many registrars or even senior registrars, even junior consultants, when they operate on patients with acute subdurals, they turn the head inadvertently too much, and then that causes constriction of the dural of the dural transverse of the internal jugular vein drainage, and particularly if the side that you have actually turned is the one with the dominant drainage, then you will find that there's a lot of bleeding. And so always make sure that you are not kinking the contralateral internal jugular inadvertently. Then the other point, I remember one of my first acute subdurals I was doing, there was bleeding from near the sinus. It was ooze, ooze, ooze. And because you have now taken the periosteum, it was very difficult to put any hitch sutures. And near the sinus, when I was junior, I did not want to make any holes in the bone to put tack sutures. One of my colleagues in Manchester, Dr. George, he uses the technique. What he uses is he puts the mini plates on the over the sagittal over the midline, and then he basically hitches the hitched sutures onto the mini plate and then tighten the sutures. So that way you can easily get midline hitch sutures done. Then I think you have to be also careful when using flow seal uh, near dural venous sinuses. I think Dr. Bhatt mentioned it. There was an unfortunate case that in a hospital that I know of, where there was bleeding from the dural sinus, transverse sinus, and use of flow seal led to the blood clot, and then the blood clot going to the heart and to the lungs. So you have to be careful. I think better to avoid flow seal if you think there's a bleeding from the sagittal sinus. The seventh point is that judicial use of bone wax as well. Sometimes I think the St. George's team about 20 years ago published a paper when they were using bone wax when they were doing acoustic neuroma. Then they found that on the scan that the bone wax was somehow in the transverse sinus. So although you think that you are putting the bone wax, somehow it goes into the sinus as well. I think for every trainee, it's really important. Would be very useful to read about, as Dr. Bhatt highlighted, about the monopolar, because there are so many settings on monopolar between the coagulation and cutting with blend settings. So understanding your instruments is really helpful. It's a shame that when I started neurosurgery, I did not know all these things, and I don't think one should go through a whole of experience to know that you should learn these things earlier on. So these are the points, Dr. Maria and Dr. Bhatt. Thank you.
Thank you very much, Naren, for your excellent comment. I'm very impressed and I'm very grateful that you joined and expressed everything that supplemented my presentation. A word about further thing, one more point when you asked me what the trainees should. I think I grew up in a time when my bosses were antagonistic, some of them, to the
Mhm.
companies because they had a fear that they would bribe us and they would make us do things which may not be in the patient's best interest. I think we should evolve from that to a mature thinking, that is, we should work with the industry, learn what is right. And I would say, of all the products, especially when we are talking about this flow seal so much, I would say when you attend some of these company courses, you learn finesse of that product, how to apply, for example, washing away or using the minimum and using some pressure from that, or wait for a while, etc. So I think one of the additional message to the trainees is to work with the companies, learn the science from the experts, and use to our advantage, and keeping only patient in the center of our activity rather than being bribed by them. And I think we should be, as a neurosurgeon, all mature enough to understand, as they say in our culture, that the swan is the one who can differentiate between milk and water, hanso hanso bako baka. So that means we should be able to differentiate what is right, what is right for the patient, what is right for us, and lastly the industry. So everything should be centered on a patient, and if we use the knowledge we gain from the industry to the right proportion, I think it is the best thing that trainees can do. And of course,
I think
nowadays there is so much information available on media and AI. Thank you very much.
Thank you so much. I think the flow seal question was an interesting one because flow seal itself cannot generate any gas, but it basically leads to entrapment of gas in the cavities. What I I have seen and what I have read about is that it leads to entrapment of the air, which is already there, like in the skull-based defect. If there is a bigger defect, it can lead to, and there is some air inside, it gets entrapped with the slow seal, and that's why sometimes they say that you have to be quite careful when you are dealing with a huge defect in the endonasal endoscopic procedures where you are suspecting there could be some entrapment of air or in the in the very tight corridors, like we have mentioned in the ventricular systems. So I think that's what I take from that flow seal. The pneumocephalus you are talking about with the flow seal. That's what I take from this. Dr. Naren, do you have anything else to share? Please unmute yourself.
I think just to
Cool, yeah, thank you.
just to say that what Dr. Bhatt said, I think with every instrument that you use, I think it's worth to know about the instrument, the engineering, and the cons and the pros, because not many of us don't know, and then it can cause problems, and which would have all been avoided had there been education the about the flow seal, about any instruments that you are using. So I fully support what Dr. Bhatt saying, that I think you should, if you are using something, then you need to know it inside out before using it. I've put the link and the image about the flow seal, and how it looks in the CT scan. Once again, I only learned about it today morning, and so one shouldn't go through life this long to learn these things. Thanks.
That's interesting, I
Thank
think,
you.
because
Dr. Parekh, word of wisdom, final.
Hello, Professor Bhatt. Excellent talk, very educative. We have learnt, I have heard you earlier also on this talk, but every time I feel you are giving something new to us. And Professor Narayan has given a wonderful comments, no doubt about it. About you were asking about using the uh, hydrogen peroxide, and I'm still using it, by the way. I'm still using it, and except in ventricular opening, I don't use. I use everywhere, and I wash it out. So I'm lucky that nothing happened so far, and it creates a nascent oxygen and creates a heat to stop the oozing. It's not an active bleeding which stops. About flow seal, in our setup, we find difficult to use because of the cost constraint. And secondly, many a times I have seen that even though the flow seal is used, we waited for some time, washed it, and after some time again it starts bleeding. So not very sure whether how many times it really controls and how many times it does control. There is a new drug, a new product which is coming up. I'm sure you know about Tacosil. Tacosil. It is going to come up in market very soon. It is not launched in India, but in this World Congress they had a meeting and they had a webinar also separately on that. And this may be very helpful in controlling the bleeding, especially from the sinuses and other areas which you were talking. And yes, I still remember your teaching that the head high is to be given in every patient. And I agree with Dr. Naren that while you are doing subdural or something, you twist the neck in such a way that there is a raised pressure because of the venous compression, and it can cause a lot of bleeding. So, learning the art of hemostasis is very, very important. Very important. That is the first step in neurosurgery after the neuroanatomy. If you learn the neuroanatomy and if you learn the art of hemostasis, maybe 50% of the work is done in neurosurgery. I'm still scared after 35, 40 years of bleeding, hemostasis. You are always worried whether you are not going to wake up in the night to reopen the patient. So this is very important to learn from you, and wonderful pearls of wisdom also given by Professor Naren. Keep it up. Thank you very much.
Hydrogen peroxide is one of the very commonly used, agents in the low middle income countries. We also have this hydrogen peroxide, but unless you use it in the carefully and in the right way, in the right dilution, and how you are actually using, you are avoiding all those the places where in the strip you have to be careful. All these things that you have to keep in mind. You can, yeah, we haven't seen so many complications, but you have to be very cautious. Where are you using it, and how are you using hydrogen peroxide? So this is very right, and yeah, I agree with you in this comment. So, any final comment from any of the panel or the
Yes,
attendees?
if I may
Can
give just two responses to Dr. Parak. When I was in UK, I used to before the hydrogen peroxide was stopped, we used hydrogen peroxide extensively. We didn't have any problems with it, but I recall reading a case report where they had used hydrogen peroxide with a spinal case, and then there must have been a leak, inadvertent CSF leak that they did not know about, and the hydrogen peroxide had gone, and then the patient had pneumocephalus and then coned. So you have to be careful when you are using hydrogen peroxide in areas where there might be a CSF leak and the hydrogen peroxide goes and gives pneumocephalus. And the second thing Dr. Parak mentioned about the expense of flow seal. I was in Johns Hopkins now about 20 years ago, and they use their own homemade flow seal, and it's amazing. They have it in about 20 mils syringe, and then the nurse makes it up before the operation, and you wouldn't believe they just use it for even with a burr hole. They will do the burr hole and then they will give it because they have got a homemade cheap 20 to 40 mils thrombin. So if you do ask Dr. Jallo how they actually make up the recipe he gave to me a long time ago, then you can get a very cheap flow seal that you can make at home rather than having to buy it. Thanks.
Yeah,
that's
Dr. Jallo is a
very
wonderful teacher.
yeah.
Please, sir. Sir, please.
Now I see that those who are fasting, their fast is. I
Yes.
know that
Yes.
those who are fasting, the fast is over in the eastern part of the world. But I see Dr. Pirza, the very senior neurosurgeon from Afghanistan, is also online. If he wants to say a word,
Yes. Dr. Pirzad, please. He's a wonderful friend. Yes. And I've also shared the link to get your attendee certificate. Please, all the attendees, click on the link in the chat box to receive your certificate. Dr. Pirzad, you are now the co-host, please. Dr. Pirzad, I think they have 30 minutes difference from Pakistan in the fasting. Is in Afghanistan. We have just broke our fast in Pakistan, and I believe that they have a little delay. Maybe he's Dr. Pirzad. I, I I don't know if he's. I also think that Dr. Shankar is attending a conference. I messaged him too, but he wasn't able to unmute himself.
that's okay. I think, in the interest of time, you may want to close. But I'm very grateful to Dr. Maria and all the delegates, including Dr. Parekh and Narayan, who have given their valuable insight, augmenting my presentation. So I'm very grateful for their presence and encouragement. Thank you.
So grateful to you, sir, for your very, very kind and wonderful talk. And it was really insightful. It was amazing to have you with us. And I hope to organize another webinar with you again because you are one of the best teachers around. And I'm also really grateful to all the attendees and all the panelists that joined us and added more value and added more interest in the topic. Thank you so much, sir. It's time to wrap up the
Thank
session.
you. Thank you.
Thank you very much, Dr. Harshad. Thank you very much. Thank
Thank
you,
you.
everyone.
Thank you. Bye 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 bye.
Thank you,
Thank you.
everyone. Time to wrap up the session. Thank you so much, sir. Bye. Bye, everyone. Thank you very much.